Hello, thank you, and thank you to Jim and Aidan for co-chairing this session at the Irish Global Health Network Conference, co-hosted between the HSE and the Irish Global Health Network. And today's theme is Irish health system resilience. And in this talk, I want to cover some of our own experience in the pandemic in Ireland, and then how that links through to the global experience. So next slide, please. So looking at our own experience here, we've had in relation to the size of our country, we've had a huge number of cases. Admissions 47,000, which represents a huge burden on our healthcare system through the successive surges in cases. ICU admissions again, 2,700 just over, again representing a very significant number of additional burden of cases, which certainly brought our critical care system close to the point where it was unable to provide high quality care, but due to our ability to redeploy staff and set up, I suppose, temporary ICU facilities in redesignated areas, we were able to keep up reasonable outcomes throughout the pandemic. Total recorded deaths just short of 8,000, and some of those, there were many of those among older people, many of those among people with chronic illness. Next slide, please. Looking at the Irish response, it's kind of widely acknowledged that we, in Ireland at least, had, despite the huge fear and apprehension at the beginning, that we had a reasonable and good public health, a timely public health response and advice through all stages of the pandemic, before we had vaccination, when there was great uncertainty, through to the vaccination program, which in many ways is the envy of the world in terms of the uptake. But that picture on the left shows the street off Grafton Street at one stage during the pandemic, or before the pandemic. On the right-hand side of the picture, I took myself coming from the Department of Health one afternoon at 3 o'clock on a Friday, showing the impact of these widespread public health measures and social restrictions, which left our streets deserted, and confined people to their homes for lengthy periods of time, and which in themselves led to secondary problems. Next slide, please. And those restrictions are well known to all of us. At one stage, people were confined in the houses, no household visits, all retail, restaurants, pubs, cafes closed, public transport available for essential workers, remote working, and really essentially a shutdown of society for at least two periods of time, for months at a time. And while that undoubtedly had an effect on people's interaction and sociability and the way they worked, it had profound implications for health, which I'll outline. Next slide, please. What was our response? Well, when we saw what was happening in Wuhan and Milan, was to increase hospital capacity as quickly as we can. Development of a test and trace service. The first test we did was sent over to England with a 5-day turnaround time, during which the adolescent concerned was kept in a hospital. We got the result back. Eventually, we peaked at over 150,000 tests in 1 week. The vaccination program, again, upscaled from something that was ad hoc and delivered by queues within hospitals to then a widespread vaccination program with dedicated centres, expansion of ICU capacity, additional healthcare staff, telemedicine. At one point during the pandemic, a quarter of all consultations were by video link, and now gone back to 16%, but nevertheless showing how adaptable and flexible people could be at a time of emergency. Any idea we had before, which encouraged avoidance of hospitalisation, footfall in hospital, was dusted down and scaled up at speed. Anything that was piloted before that seemed to work was implemented, and suddenly, after years of talking about enhancing community care, we were actually implementing it. At the same time, strengthening infection prevention and control measures across every healthcare entity, public and private. Next slide, please. The vaccine response I mentioned before, in some ways, the envy in terms of uptake. And just look at that uptake. For those aged older, almost 100% of the population fully vaccinated or primary vaccine course. As we go down through to the first booster, the uptake perhaps a little weaker, not surprising, because the same incentives might not have been there between either fear of serious illness and also because of perhaps the freedoms that came at one stage with vaccination were no longer available for people, whether or not they were vaccinated. But we did see still a very strong uptake for that first booster, approaching 80%. Second booster, perhaps less so, although strong figures remain in those aged 65 and older, perhaps again reflecting not just their degree of compliance, but also that they had more to gain by keeping their booster status up to date, and perhaps they were more tuned to listening and complying with the advice they were receiving from multiple clinical and public health voices in a very consistent manner. One of the important facets of our programme was this consistent communication and advice and maintaining the trust of our population. The next slide, please. So let's look at the indirect. I said earlier there were some secondary consequences to what happened in the pandemic. One was, of course, a sudden drop in healthcare interactions. That red line on the graph above shows the ED attendances falling abruptly during that period of April, May, June, and again, ED admissions. And if you extrapolate beyond that to just about every healthcare interaction, GP attendances, cancer diagnosis dropped according to the National NCRI, National Cancer Registry, by 15% for 2020. Then proxies for cancer care, biopsies, endoscopies, other procedures, other measures, other interventions, other interactions that were associated could lead on to cancer diagnosis intervention dropped considerably. Even on, when I say the softer side, not so much in terms of how they're measured, we see impact in terms of older people deconditioning, malnutrition, multiple times increase in the presentation of eating disorders among adolescents. All in all, showing that as the pandemic subsided, there was a debt to be paid in terms of the consequences of isolation, of suspension of treatment, of people perhaps developing a kind of tunnel vision or funnel vision even for COVID-19, as if it was the only illness that existed. Next slide, please. So looking back at clear health systems, not prepared for prolonged multi-phase crisis, certainly not here in Ireland or anywhere for that. Health systems found they were surviving on edge. That included those healthcare systems hit early in London and Northern Italy, relatively well resourced, but totally incapable of dealing with the sudden surge in illness coming through and the requirement for intensive care and respiratory interventions. Hospitals didn't have surge capacity to deal with this. And what happened as a consequence, as I outlined earlier, is that other healthcare services suffered as a consequence. We scrambled in Ireland, as with other countries, to get access to information, equipment, supplies, tests, workforce, PPE. And like other countries, we found that systems of care that had evolved that may not have been directed by what was in people's best interest, either clinically or from the point of lifestyle, were really corresponded poorly to the needs of the pandemic, most notably perhaps the idea of congregated settings for older people, something we'll always need, but surely should not become the default setting for older people who can no longer manage at home. Should it be the case that we continue to encourage congregated settings as the only alternative? Surely we can look at better ways of maintaining people in some kind of home setting where they're not exposed to the risks of a pandemic. And most last but not least was surely the impact on healthcare workers has been huge in terms of exhaustion, depletion, and the psychological toll over a protracted period. Next slide, please. Lessons learned. Well, upscaling innovation, those ideas, as I said, were tossed around for too long over how we should move care to the community, how we should enhance community care, now being upscaled with significant budgets within the HSE. And a recent paper for the Nuffield Trust highlighted that healthcare systems across the developed world certainly are escalating rather than pulling back on transformation, on this move towards a broader interpretation of where healthcare can be delivered and of the staff that can deliver healthcare. So that kind of reform of healthcare, the move towards integrated care, healthcare systems are accelerating this trend rather than suspending it. Public health, certainly some of the stars of the pandemic in terms we'll never be able to count the amount of cases avoided, the deaths avoided through their intervention. One thing with absolute national level and international level was how much this exposed healthcare inequalities. And the catchphrase went out during the vaccine program: "You're not protected until everybody's protected." But likewise, we were reminded time and time again by Mike Ryan otherwise that we cannot just protect ourselves alone, be it one community, one family, one nation, without addressing the inequalities, whether it's the vaccine program in terms of protection for the whole world. Of course, clinical leaders, but a huge part we found, especially when it came to those public health messages, people maintain their trust of the healthcare professions and listen to their advices. Next slide, please. It's not a new concept that the world wasn't ready for a pandemic. The World Health Organization said way back in 2011 that we were ill prepared to respond to severe influenza pandemic or any similar global public health emergency. And there's ample evidence going back before this pandemic of perhaps a lack of preparedness, and the most recent review by the Lancet post-pandemic does highlight and is quite critical of some of the international responses in terms of our state of readiness, or how prompt we were in responding to those early signals, and how quickly we took the necessary actions to protect our population, be they in nursing home populations or be the population at large through specific non-pharmacological methods. So the learning has not yet ended, but certainly the learning began before the pandemic because the signs were there that we weren't well prepared. Next slide, please. And of course, as we found out, the idea that we can be immune from pandemics is a fallacy. It's a much closer world, faster travel. By the time a case emerged in Wuhan, they probably were already seeding in Italy. By the time they were in Italy, they were already in London. By the time they were in London, it was well in Ireland. And it is simply not plausible or feasible. As we discovered during the pandemic, there was lots of calls for a zero COVID policy. To do that, and the price one would have to pay to lock a country down indefinitely in terms of travel is something that is hard to conceive and hard to really back in terms of our experience during the pandemic. And with emerging infectious disease, we now have certainly in Ireland and other Western European countries, aging populations, more immunocompromised individuals, more people living with chronic disease, public health systems which were not really well attuned or resourced for the pandemic, and other and of course, as I mentioned earlier, we were not able to withstand sudden surges in patient presentation. Next slide, please. So above all else, our message here was, as I referenced the recent Lancet Commission, was that our alert system was not fit for purpose. We were WHO criticising that article for its response and lack of preparedness, but I think the criticisms went well beyond any institution or country, and we would do well for all of us to learn from them rather than attribute blame to each other. Next slide, please. So what the WHO said was it's a wake-up call of how we live our lives. It's from Mike Ryan. It's highlighted the inequalities that exist in the world, not least during the vaccine program. We need to invest in healthcare rather than in arms. Unfortunately, we've seen wars break out, one significant war on the European continent since then. We're not all well. Everybody's well, and we must share the vaccines, which were I suppose that's when the battle began to turn, when the vaccines became available in an amazing time, representing a unique, fruitful collaboration between research companies, universities, healthcare systems, and astonishing achievement when one looks at the normal timescale development of vaccines. Next slide, please. The social determinants of health are well known to us all. And these figures come from our own census, and it shows those the inverse relationship between skill, education level, and age-adjusted mortality rates. And anybody involved in public health will know how they can extrapolate from this experience through to geographical areas in the UK from the Black Report, and of course how we can go beyond that, looking at not just experience within countries, but between countries. And the pandemic cruelly exposed disparity in experience between socioeconomic groups, and also between poverty and wealth. Next slide, please. For global health turning in our own, and we're co-hosting this conference, three sound reasons for our own approach in HSE, and just acknowledge the work of David Weekly and Tora, who I've worked with before in this area. It's the HSE mandate to provide health and social services to the population of Ireland. Ireland is committed to the UN Sustainable Development Goals as a partner in the government's international development policy, and in doing so, we work with other countries on health issues, sharing solutions for problems that we share with all countries. Next slide, please. And part of the work David and others have led out on has involved us in working in a shared way with Mozambique, Tanzania, Zambia, Ethiopia, and Sudan. Next slide, please. An example of quality of care, and it's Philip Crowley, who's been championing this for many years, working in Mozambique, and a previous Director General of the HSE went to Mozambique with Philip some years ago to witness for himself the impact on our quality improvement work and enabling work in Mozambique. Next slide, please. So looking at our experience here and the global experience and the overlap between them, as I said, the common theme for the pandemic, and one that Mike Ryan repeated again and again, was how it exposed health inequalities in people's individual experience. The pandemic, it exposed disparity in how resources are shared. It endorsed the primary care approach of sláinte care. It also perhaps hopefully made us more attuned and attentive to a further crisis we face, which is that of a sudden requirement for us to need to house and adopt and take care of asylum seekers. And I'll touch on that shortly. In Ireland, I'd like to think that our experience in the pandemic contributed to our understanding and our willingness to embrace the incoming refugee population of Ukraine, which now stands at over 50,000. Next slide, please. And touching on the Ukraine, the approach has been multifaceted, again led by David, who's informed others and many others. Margaret Fitzgerald, who's recently retired, was a champion in this area, and many people in public health have contributed hugely to the HSE's response. There was donation of medical equipment supplies. There were individuals who went out there, including a public health specialist who went out, Gabriel Fitzpatrick went out to work in Ukraine for a number of months. And all this was done in collaboration with and facilitated, I hope, by our own HR within the HSE. Next slide, please. As I said, over 50,000 people have now arrived from Ukraine. Immediate housing issues, city and the congregation settings led to its own problems and led to its own risk in terms of not just provision of dignified and accommodation that people want for families, for children, but also particular exposure we may have had in terms of outbreaks, in terms of vaccination, in terms of bloodborne viruses, and then the most basic provision that people would want, which is the provision of primary care. And this presented a huge challenge to the HSE. Again, I'd like to think that we stood up to meet this challenge at a time when we had existing housing problems for our own population, and indeed existing demand capacity mismatch for primary care. But it was the right thing to do. It was politically led, and our medical and public health community embraced this, as indeed did other departments within government. And we're working with public health colleagues to try and do a catch-up vaccination scheme now for children from Ukraine, and also to identify and offer testing for bloodborne viruses to people from the Ukraine too, in line with the major risks identified by public health colleagues. And there was some individual cases of heroic medical evacuation, bringing injured people from battlefields or from innocent civilians from bombs and other war-associated injuries to Irish hospitals for intervention, for treatment, surgery and rehabilitation. Next slide, please. I mentioned these particular groups and focus, and all those, we began identifying the major risks, and then the hard work began as how we were going to respond to those risks. And that has led to distinct plans being laid out, and also operational groups set up with our colleagues in operations to address each of these in the themes outlined here. Next slide, please. So coming to a close, what has the pandemic taught us? One is to improve population health and the importance of addressing inequalities, and the part of the family of the medical profession which most capably is most attuned to this is of course public health. And we have we expanded the workforce hugely. It coincided at the time we were appointing consultants in public health, and part of this work involves, ironically, from Crowe Howard report, pulling away from what was seen as an over emphasis on health protection to focusing the other significant pillars of public health: health improvement, health service improvement, health intelligence, and doing so, allowing public health consultants to work at their full license, addressing and proposing strategies to address inequality from within our country. Innovation, health care delivery, I mentioned those before. We were laggards in this, as were other countries, and perhaps too cautious in our approach. That caution was thrown to one side during the pandemic. I'd like to think that normal conflict won't resume, that we'll be able to hold on much of what was good during the pandemic. Data enabled health services. A big learning for us in Ireland was the lack of disease registries, the lack of our ability to identify particular vulnerable populations for vaccine. Much of this was done by paper, by manual exercise, and it simply isn't good enough. And we need to work towards a system where we can identify our at-risk population for any intervention we may need, be it vaccination or otherwise. Next slide, please. Perhaps I'll finish with this is the workforce, and this is a picture I took in the height pandemic of an infectious disease team working in Cork University Hospital. And it's poignant in a way because I had named all of them in the associated tweet or whatever, but they're hard to identify because they're almost anonymous behind their masks and PPE, and it represented a grueling period for healthcare workers going in and out every day. Work was hard enough, working in this kind of environment with the fear that must be pervasive at the time, and the absence of vaccine made it much more difficult. And that same workforce we're relying on now to manage the post-pandemic cleanup, the catch-up for later diagnosed cancer, for upgrading of cancer, for non-attention towards mental health difficulties and eating disorders I mentioned before. And and working with this depleted workforce, enhanced in number certainly, is a challenge, and addressing their own needs post-pandemic. Next slide, please. And I mentioned their exhaustion, but also recruiting the additional people we need for new models of care, for retaining people, training people, and addressing that imbalance we had for too long between a system that was that needs resource in the hospital, needs more resource in the hospital, perhaps was under-resourced in the community, and developing those new models of care that will allow a more holistic and balanced healthcare approach to people who need the access to healthcare in Ireland. Next slide, please. Just to finish, the slogan of Michael Ryan's "Have no regrets, move quickly, you'll never win," and that was a slogan that worked well during the pandemic. There's some degree of regression now, without doubt. We've moved to a normal conflict, has resumed in certain ways, but it'd be nice to hold on to that innovation and that positivity we had, born out of necessity, but nevertheless something that achieved so much in such a short period of time. And the other quote from Dr. Tedros, one of the clearest lessons of the pandemic is the world needs a stronger foundation for global cooperation and pandemic preparedness and response rooted in human rights and equity. Now more than ever, we must protect the right to health and health for all. So, Míle buíochas, and I'd like to thank the conference organisers, and again to thank David Wheatley and Matora and the whole team. Good night, Mike.